A warm welcome to everybody joining this World Evidence-Based Healthcare Day webinar on an introduction to inequity across evidence ecosystems and the implications for global health equity. We have over 200 people from 58 countries registered today, so we hope you're looking forward to a diverse and lively discussion. Thank you for taking the time out of your busy day to listen and contribute over the next 75 minutes. By way of introduction, my name is Bianca Pilla and I am the chair of the World EBHC Day Steering Committee and the Director of Global Relations at JBI, and it is my great pleasure to convene this webinar. Now, while we have people from all over the globe with us today, I'm joining you from Adelaide, Australia, and therefore I would like to begin to acknowledge that we are hosting this webinar from the lands of the Kaurna people. I also acknowledge the traditional custodians and people of the various lands on which you work and live today, and the Aboriginal and Torres Strait Islander people participating in this webinar. As we share knowledge on World Evidence-Based Healthcare Day, may we also pay respect to elders, both past and present, and their knowledge and experiences. If you'd like to join in social media about this webinar or indeed about World EBHC Day, you can do so via this hashtag and handle. And so this webinar is actually the opening event for World Evidence-Based Healthcare Day in 2023, which promises to be a busy 48 hours or so globally with a wide array of online and in-person events and plenty of discussion across social platforms if the previous 3 years are any indication. Now in its 4th year, World EBHC Day began in 2020 as a global platform to raise awareness of the need for better evidence to inform healthcare policy, practice and decision-making to improve health outcomes globally. Health professionals, researchers, policymakers, patients and others across the globe are working together to address serious global health challenges and improve the outcomes of global health through evidence-based healthcare. And World EBHC Day is no exception, being driven by 7 global leaders working in partnership, a coalition of the willing, to create a global platform where people from many different disciplines and sectors can come together around a common agenda, and that is using evidence to improve lives. In 2023, we have reached the midway point for the 2030 United Nations Sustainable Development Goals agenda and a global commitment to leave no one behind. However, the global crises of humanitarian disasters, climate change, and health pandemics are all impeding progress and exacerbating global health inequities, highlighting the urgency to strengthen local and global evidence ecosystems to address societal challenges. According to the World Health Organization, achieving an impact on global health and equity is the ultimate aim of better use of research evidence in health decision-making. However, the ways in which we prioritise, commission, fund, produce, synthesise, disseminate, translate and use evidence to inform health policy and practice can both worsen existing health inequities or help to overcome health equity challenges. And so to this end, the 2023 World Evidence-Based Healthcare Day campaign calls on the global evidence community to share their experiences on how to strengthen evidence ecosystems to advance global health equity. To further this discussion, it is my great pleasure to introduce to you Dr. Nasreen Jessani, who will be moderating our panel today. Nasreen is the head of the Knowledge, Impact and Policy Cluster at the Institute of Development Studies, where she spearheads a research portfolio that explores innovations and advances in evidence ecosystems, including the relational, social and political dimensions of evidence use and impact for global development. Over to you, Nasreen.
Thank you so much, Bianca, and welcome again, everybody from all over the world. It's exciting to know that we have registrants from 58 countries. It is my pleasure to be moderating this particular panel for today. Thank you for the invitation, Bianca, and welcome again to everybody that's attending. So just a quick reminder about what the objectives of today's panel is. It's really to ensure that obviously while there are several complexities that impact health equity, this is just an introductory discussion. And within this discussion, we're not focusing on the general state of health equity because I believe that lots of discussions have been happening about that globally for many, many years. What we're really going to focus on is about the evidence ecosystem and inequity or equity across the evidence ecosystems from panelists' global experiences. And of course, the relationship between the inequity or equity in the evidence ecosystem and its link, of course, finally to people's health. And we hope that this will spark a discussion about the state of the evidence ecosystem and its role in global health equity. So I have the distinct pleasure of inviting those to join us on this panel. And before I ask our panelists to share their, to put their videos on, maybe it would be helpful to have a quick summary of definitions so that we're all kind of on the same page when we're thinking about what do we mean by an evidence ecosystem. So this is a working definition by the steering group of the World EBHC Day. It is in no means final, and there might be things that are missing from this, and we would love to hear from you on that. But in summary, we see an evidence ecosystem comprising of actors, actions, and processes that together determine the role of evidence in policies, practices, and public decision-making. And these could be at the local, national, or global levels. The different processes and practices could include things like priority setting, commissioning, funding, the ethical approval, the production, synthesis, translation, communication, dissemination, and use of research evidence. The interrelated links within these systems are underpinned, of course, by formal and informal relationships, collaborations, cultures, and the context in which decisions are made. I'm waiting for my screen to change, but we do have also a working not a working definition, but how we're interpreting health equity for the purposes of this panel as well. It's a definition that's from an article written in the Journal of National Medical Association in 2022. So it's an updated definition from what we've seen in the past. Health equity here means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, powerlessness, and their consequences, including the lack of access to good jobs with fair pay, safe environments, and quality education, housing, and healthcare. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. Thanks, Bianca. And so it is my distinct pleasure to be hosting this panel alongside several esteemed colleagues in this field. If you could all put your videos on so everyone can see you as I introduce you. So Dr. Lynn Hendricks, you'll see where she is based at the moment in South Africa. I see that we have many colleagues here also from South Africa. Lynn is a lecturer in the Division of Health Systems and Public Health, but she's also a transdisciplinary researcher with a keen interest in co-creative and co-productive research within communities. And Lynn is extremely involved in working with digital mediums as well as primary arts-based methods. If I can ask panelists to keep their audio off at the moment, that would be great. I'd like to also introduce Jordi Pardo. He's a project manager at the Center for Global Health in Ottawa and the managing editor of the Cochrane Musculoskeletal Center and senior advisor with the Health Equity Thematic Network. Jordi hails from Latin America and has lots of experiences, particularly in this field that he will be sharing with us. Lawrence Mbuagbaw is a research methods scientist and the co-director of Cochrane Cameroon and a convener of the Campbell and Cochrane Equity Methods Group. His research interests are infectious diseases, maternal and child health, health system strengthening, and the intersection of these fields. We go far east again into Australia. We welcome Ritin Fernandez. She's the director of the Center for Evidence-Based Initiatives in Healthcare, engaging academics, nursing, and multidisciplinary clinicians to develop clinical research with a focus on multicultural health, in particular the Indian community in Australia. And last but not least, from India, we welcome Soumyadeep Bhaumik. Soumyadeep is a medical doctor and an international public health specialist. leading methodological work in India's only rapid evidence synthesis unit. He is passionate about addressing justice and equity in the research and global health ecosystem. Welcome, everyone. And I lost that a second ago. So here are the various aspects of the evidence ecosystem that we shared in our definition earlier. There could be parts of this puzzle that you are passionate about, or parts of this puzzle you think are missing. Please write to us in the chat. We'll be happy to hear from you. But given that there's so many aspects of the evidence ecosystem, we can't speak of all of them today. So we're going to have different panelists speak to different parts of it. So Jordi here is going to be speaking particularly about the prioritization process and his experiences of inequities or equities that have been supported or hindered within the evidence ecosystem with respect to prioritization. Soumyadeep will speak to us about the commissioning and funding of research. Lawrence will speak to us particularly about the production of research and the implications also for training. Ritin will be speaking to us about her experiences with the synthesis aspect, also crossing over into training of that. Lynn has done a lot of work, as mentioned, in the arts, and she's going to be speaking to us about knowledge translation and particularly participatory methods of involving communities, as we also speak about policymakers and practitioners. We'll be also speaking about participants of the research process themselves. So that's a quick overview on what you're going to be hearing today. I'm going to start off with inviting Jordi to speak to us about the prioritization processes. And I'm giving each panelist 3 minutes to share their story with us. And we'll be moving through our panelists in that way. Jordi, the mic is yours.
Thank you, Nasreen, and thank you, Bianca, for the invitation to participate on this event. It's really exciting to be able to contribute in here. So many thanks for this opportunity. Well, I've been tasked with this, summarizing the key ideas on how global health could be included and global health equity could be included in the setting of priorities. And I would like to start with a few examples of priority setting process that I've been involved directly or indirectly, or that some of the members shared when we were preparing this session. So Lawrence, I will take some of your stories as well. The first story I would like to talk was a priority setting process that we set up in osteoarthritis. And we were lucky enough to have an important group of patients, clinicians, policymakers. And we managed to get together in the framework of the Singapore Cochrane Colloquium many years ago. At that point, our objective when we started the whole process was to try to get which reviews we should be working on osteoarthritis, which interventions should be more meaningful for patients. However, it was soon obvious that the patients were not interested in that. Like the main questions that they think was going to have a bigger effect on their lives was actually about how to effectively communicate with the healthcare practitioners. And we ended up with a lot of questions that were related into how you communicate effectively with healthcare practitioners. That was not useful to us as a Cochrane musculoskeletal group that at that point that we were trying to look for reviews in our set. However, we really make a big difference of setting up, addressing what were the needs of the patients, and we sent a lot of these reviews to the consumer and communications group in Cochrane in order to address that. And in this sense, it was clear that it was a mixed match of what the professionals thought that their arthritis patients were looking at, or what they were going to look into at. And there is a second example that actually, talking with some colleagues from Campbell, came out, that it was talking about people with dementia. And on dementia, it seems, well, if you have people with dementia, how you're going to involve them? And actually, they did the effort of trying to involve some of these patients and look what is important for you. And it was not an easy process. However, again, when you talk with the healthcare practitioners, with the researchers in the area, you get a lot of questions about new treatments and new approaches and what are the things you can look at. But actually, the patients were really focused on saying what I need for living well, what I need around me, what is the support that me and my family need in order to have a way of living well in my environment for as long as I can. And that absolutely switched the mood of everybody from a biomedical approach to a much more psychosocial sense of questions that were coming up about how we better support the life of these people. And a lot of the aspects were less about treatments and a lot more about the support system that we are generating around. And on that sense, it's interesting to see how you change completely the approach of what is important or not, just involving the people who are actually going to be more affected by that. There is a final story that Lawrence shared when we were preparing this session. This is about how we prioritize things when we are disseminating. This is often something when we're thinking of prioritization, we just think what is the new research that we can do, but also it's important to look about what we prioritize that we want to disseminate. No, and I'm really pleased to see that Lynn will also have some experiences on co-production on this aspect later on, because his story was about what happened in Cameroon. In Cameroon, there is a strong French community, and they were using a lot of Cochrane reviews that were translated by Cochrane France to look for dissemination. But soon was obvious to say, well, a lot of the reviews that were coming from Cochrane France were not actually relevant for the Cameroonian context. And on that sense, they started a different process of saying, well, let's ask the people what are the things they want information on, and then we're going to look if there is Cochrane reviews, and then ask Cochrane France to translate these ones. And that totally changed the shape of what is the kind of information that we were sending around, and putting a bit more thinking about what is the information that we want to disseminate, and how we prioritize what are the things that we are going to send to the community, and involving those who are going to use the information is extremely important.
Yeah,
so why is that important, no? And why it matters for health equity? Well, the first one is that when you get those who has the most legitimate interest in decisions of setting priorities, you are going to change what are you looking at. And this is extremely important. We had a wonderful session at the Cochrane College in London on co-production, where a lot of examples about what happened when you're giving voice to those who usually don't have a voice on setting up the research agenda, and how that transforms the process that you are doing and helps to make real difference in the real world. That's one key message that I would like to take. And this is important because we are not working in a plain level field. We have actors in the whole research area that have a new influence on what we set up. We had also in the London Colloquium a session on commercial determinants of health. And it was clear that if you don't account that there are some transnational actors with a lot of influence to make primary research and to set up what is the things that we are allowed to talk by putting money into this kind of research and so on and promoting it, you can, if you're choosing whether you're doing your evidence synthesis and where are the most studies, you may end up of doing studies on alcohol abuse, focusing on peer pressure or about how to self-manage and drinking responsibly, instead of focusing the research agenda on what is the influence of marketing strategies or the normalizations of unhealthy behaviors in social media or in the different things. So from that perspective, giving voice to those who don't have voice to really address their needs may help us to focus on what is needed and not on the priorities of others that may not be what is really important for the people in the field.
Thank you, Jordi. And I think that's a really important aspect that you bring up about voice and, who gets involved in the prioritization process, whose voices are reflected, and whose priorities are we really focusing on, and the links that has in terms of the production of the research, but also the funding of the research. And I'm really glad that we have panelists that will be speaking to that. For those of you that might have questions, particularly to any of our panelists, please drop it in the Q&A part of the Zoom chat. Thank you. So that's a nice segue actually to Lawrence. Lawrence, you had a story from Cameroon that Jordi shared with us. I'm sure you have a different story that you're going to share with us, but you have a history and passion for thinking about training with respect to production of research and the training of the next generation of researchers. And obviously the equity concerns and approaches to embedding equity throughout this kind of training is front and center of a lot of the work that you've done. Could you perhaps share with us one or two of your stories from this kind of endeavor over time? Thanks, Lawrence.
Thanks, Nasreen. Jordi, you'll be receiving an invoice in the mail. So I started off with as a medical doctor in Cameroon, and I had particular interest in determining which was most important to give my patients, efavirenz versus nevirapine. These are people living with HIV. And I connected with some colleagues who said this would be a good topic for a systematic review. At the time, I didn't know what a systematic review was. I connected with folks in South Africa, and I received training in systematic review. So I had to fly over to South Africa. I got training in systematic reviews. Since then, I have come back and have led several workshops in Cameroon and built capacity in several other parts of the world. We now have a Cochrane Africa network, and I also co-direct the Francophone hub of Cochrane Africa. So I will talk a little bit about the issues with regards to equity and the languages that people speak. And all this work, all these experiences have led me to do some research on the publication practices of people that we train to generate evidence from the African continent. So there are 4 points I would like to make. The first is that there are limited opportunities for people to train themselves in evidence synthesis. At the time, I had to fly to South Africa, 8-hour flight. This is not easy for people everywhere in the world. And I had to do the training in English. So automatically, if you did not speak English, this would be extremely challenging for you to do. And we still have many academic institutions that don't recognize evidence synthesis as useful evidence or as good research. So many people do not do evidence synthesis. The next point I want to make is that because English is the language of science, there's always a linguistic divide between the people who speak English and those who don't. And I quote myself in a paper I wrote several years ago: if evidence aims to alleviate disease burden, then the efforts should be directed at the region of the world with the highest burden, which is Africa. And surprisingly, Africa has the highest number of French speakers, with about 115 million people spread across 31 countries, right? So this makes it challenging to build capacity for evidence synthesis when we're building capacity in a specific language. Some progress has been made in terms of translating training resources, but there is still a lot of work to be done. The next point I want to make, which slightly overlaps with what Jordi mentioned in priority setting, is that the training opportunities themselves are, for the most part, tied to funding. And this funding is based on priorities which were not determined by people in low-income countries. If you're a trainee, a postdoc in a low-income country, and you're looking for advanced research training in evidence-based healthcare, you would find funding opportunities for HIV, for malaria, for TB. But guess what? These conditions are the 4th, 7th, and 8th causes of death in Africa, suggesting that somewhere along the line, we are working hard on priorities that are not ours. We are not working on the conditions that affect us the most. And we are not training people to address these problems. So that's another issue. And my 4th point, which is more on a more hopeful note, is that when you look at the publication practices of the researchers who are trained in Africa to do systematic reviews and Cochrane reviews in particular, you would find that they are looking for more diverse outlets for their research, and they are using different methodologies beyond just systematic reviews of effectiveness. So people are trying to answer questions about diagnostic accuracy, about prevalence, about prognosis, and they're also doing more and more qualitative reviews. And this is important because these are some of the questions that are most important to us. If you were to say, well, we want to fund research in Africa, you should do a systematic review on which treatments are best for prostate cancer in Cameroonian men. The first question I'll ask you is, what is the prevalence of prostate cancer in Cameroonian men? And those are many questions which we haven't answered yet, but we've jumped the gun and we're trying to answer other questions which are probably more relevant to people in the global north, right? So there's a shift towards people using the training that they have to bring it back to address the kinds of questions, the kinds of topics, and the kinds of methodologies that are more relevant to them. So thank you very much, Nasreen. That's my story.
Thanks, Lawrence. Really fascinating. And I love that you ended on some hope there. But I think the issue of language and access is a really important one when we talk about equity and in the evidence ecosystem. And I think that that's front and center of so many discussions, and I'm glad you brought it up. And particularly also that training opportunities are linked to funding that's based on priorities that are not made in the countries in which either the training opportunities exist, or a lot of the training means you have to move to another country to be able to access that kind of training. So PhD opportunities in high income countries versus in the countries in which many of these researchers are actually based. So I think that's an interesting perspective. And I'm hoping, Ritin, that you might have something to say about that when you talk a little bit about what you do in terms of training and synthesis, given that Lawrence spoke a lot about that. But you also brought up a really important point about surveillance, just basic data and information to guide in some ways how research questions are relevant and not. And I think that speaks to the fact that this is an evidence ecosystem and that there are many forms of evidence. And while we speak about research predominantly, we have to recognize that there's so many other inputs to the evidence ecosystem that combine to assist with some of this prioritization and decision making. So lots to unpack there, but a really nice segue to the work that Ritin does in terms of the training and synthesis, particularly in diaspora communities within Australia, but also overseas in India. And so would love to hear stories that you have, particularly in synthesis, on the synthesis front. Over to you, Ritin.
Can you hear me?
Perfect. Go ahead.
Thank you. Thank you very much, Nasreen, and thank you to the organizing committee and Bianca for inviting me to this presentation. I'm really privileged, and thank you to all the audience for attending. So I'd like to start by saying that we live in a data-driven world, and all our health decisions are made on the best available evidence that we consider as the best available evidence. But most often, these data are often from select populations, select languages, and this can unintentionally encode biases or perpetuate disparities and inequities. What I would like to talk to you today, in short, in 3 minutes, is about my journey working in a collaborative team, working towards an evidence synthesis project with colleagues in India and in Australia and in many LMIC countries. I found this has been a real remarkable and transformative experience for me. Like Jordi had said, there are different questions that people ask. So this group of people wanted to, of my colleagues, wanted to ask us certain questions, but all the patients wanted to know was, how will my pain be treated? A simple question, while the group wanted to ask questions about which injection is superior to another injection. So we took the patient's priorities and started working on a research project. And the members of the team represented diverse backgrounds, professions, and perspectives, but we all shared a common vision as to how to generate the best evidence. So moving on this trajectory, the first thing we did was to have capacity building. So we organized workshops and training sessions, both in India and in Australia, quite a few in India and did some in Africa, and some mentorship programs so that every team member had the knowledge of and skills to contribute meaningfully. So we believe that everyone should have the necessary tools to effect change, and only then can we have equity among our colleagues. So we also developed some agreements and partnerships, and through formal agreements, we outlined our goals and equity principles, and having these documents actually provided us with a strong foundation for a collective effort. Communication was a bit difficult, but we managed to have communication, both written, verbal communication, Zoom meetings, and we had regular meetings so that we can share the knowledge, share the resources. One of the issues that we had was the lack of resources, lack of access to databases in the LMIC countries. So collaboration helped with getting access to the databases. And that's one of the biggest challenges that we faced, was access to resources by our LMIC colleagues. So in order to have a meaningful impact, we aligned our work with the local priorities, and our reviews were done according to the local priorities. We had numerous challenges along the way, and there were moments when there were differing opinions and our opinions all clashed. But the shared vision that we had to enable us to complete the review kept us together. So our diversity was a strength. It allowed us to consider all the different perspectives and adapt our approach. So we evolved from a group of individuals. So we were all different individuals, didn't know each other when we started, into a community, and we were bonded by our shared mission. After 2 long years, we finally finished our project and the evidence was complete. And that was then implemented in the practice. So what gives us hope is that there is positive change is possible through collaboration and commitment to equity and a respect for local priorities. So that's my story.
Thanks, Ritin. What a great story, and nice again to end on something exciting, something that worked. And I think what you mentioned in terms of having very deliberate principles for equity in partnerships being documented. I think that's really interesting, that there is a modus operandi and there's a form of accountability, but also a form where all partners felt like this seems fair and something to continue to go back to be able to enforce that kind of value. It is really interesting. And I wonder if we can come back to hearing some more about that later in terms of, best practices or good practices for partnerships moving forward. Also really important in terms of equity is to understand the power dynamics between partners when we're working across different cultures and contexts. Super. Thanks so much, Ritin. And that takes us very nicely in some ways to our next speaker, Soumyadeep, who thinks about power and issues quite often. And he's going to focus a little bit on talking to us about the funding part of the ecosystem and the commissioning of research as being an important part in terms of how equity or inequity plays out and its impacts on programs and policy. Welcome, Soumyadeep. We look forward to hearing your experiences. Over to you.
Thank you, Nasreen. And I think it's really great that and made my job easier from what the earlier panelist has said. It sets the tone for what I wanted to discuss on. So, we talked about how priorities are not set by countries and there are problems in terms of languages and other things. So that's a key issue in terms of doing evidence, like equity sensitive evidence synthesis. And we all know that there's not much demand of equity sensitive or evidence synthesis with equity lens, because it's much more complex than just knowing if an intervention works or does not work, because we are now talking about, oh, the intervention works, but not in this group, or works differentially in different groups. So it really makes things much more complex for policymakers, program managers, and others who want to implement this intervention. But there's also a justice cause around why we should be doing that. But not going without it, I think we have been lucky to have funders and evidence commissioners who have actually quite helped it. One approach we were able to do in India due to an WHO Alliance for Health Policy Systems Research funding is set up a rapid evidence synthesis unit. This was actually done in 3 other countries, Georgia, Zimbabwe, and Malaysia. And this allowed us to do evidence synthesis, which for the questions for which were not asked by us as researchers or academics, but this were demand driven. These questions were coming from decision makers or people who needed evidence from the public systems. So these were public agencies asking us for questions. And we actually saw the benefit of how we could use this during COVID-19, during the first phase when India was preparing for the national lockdown. We did get questions from the authorities around how community health workers can be used, and we were being able to do evidence synthesis on how community health workers have been used in pandemics globally to give them some suggestions. And it looks, and at that point when everything was unknown about a new disease, having some sense of how they have been used in other pandemics in different countries was quite crucial to that aspects. And we were able to highlight some very important equity issues in terms of what community health workers, mainly women, face and how they are also affected during pandemics. So these inputs are really, really important. And sometimes, and this experience help us to frame questions and discuss with commissioners of funders later to be able to negotiate and make them understand how we can inculcate equity in the system. So I think this was a very valuable experience for us, and it helps us understand how we can actually work in the system with policymakers to do equity-driven work. And this is something we really benefited from, and it gives me hope that it is actually possible to do a lot of good work with the resources we have in place in terms of equity. Thank you.
Soumyadeep, and that gives a different kind of perspective on how prioritization happens when it's demand-driven research, particularly in where rapid evidence synthesis is needed, rapid reviews, and you're responding particularly to queries and questions from decision makers. It'll be interesting to know, perhaps if we have time in the later part of the discussion, about how that was balanced with the priorities of the communities. Because particularly in COVID, we found, I think globally, that again, those questions were quite different in terms of what did the governments need to know to make decisions on the COVID response, but also what communities wanted to know and how they wanted to be communicated with. So maybe we'll get to that in the discussion part. But speaking of communication, this is a really nice segue to introduce and invite Lynn, our next panelist, to talk particularly about the knowledge translation aspect of research in the evidence ecosystem, to think about, to share a little bit about her experiences on engaging with communities, particularly on communication dissemination, but also in terms of research engagement in South Africa. Over to you, Lynn.
Thanks, Nasreen. And I'm really in a privileged position to go last out of the panelists, because I'm really inspired by the stories that have come forward. And I just want to talk a little bit about, my experience over the last few years in doing research around HIV infected young women who live in communities here in South Africa. And I started out by looking at, systematic reviews. I was conducting reviews of reviews. I was conducting qualitative evidence syntheses, and I was looking for answers as to what are the barriers and facilitators of adherence to medication. And I think over that 4-year process of doing review after review, I found that, as we publish these reviews, a whole new set of systematic reviews came out, all with the same answers, but nobody was getting to the bottom of the issue. And so I started looking for the gaps. And we identified population gaps. So for young people who had perinatal infections of HIV, there wasn't a lot of information. And I thought, we really need some primary research to plug these gaps. And we started thinking through about how we access this population. And we went through the clinics, went through ethics and all of that. And I thought, but what is it that we want to contribute to the evidence? What is it we want to say that's new? Why are we doing this? What is the purpose? And then I realized that actually it wasn't me that had to decide what we wanted to contribute. I actually had to ask them what it is you want people to know. So what is it about taking your medication, about living with HIV, about accessing the health system that you struggle with? And which parts of those stories do you want to tell? And the groups that we worked with, and I mean, we spoke about language being a barrier. They are not all English speaking first language. Yes, they speak English, but they don't necessarily read in English as eloquently as they would in Afrikaans or in isiXhosa. So we use participatory methods, and we started out asking them what it is that you would like to share with us about your story. What do you think people need to know? How can people support you? And then we started designing objectives. And one of the key things that we did, which I found really helpful, is I took what we had learned in the literature and we translated that evidence into stories. So these are first-person stories. We published the review as a first-person story. It reads, you can read it as a story to a child and say, you know, I was walking to the clinic with my mom. So I could read these stories directly from the publication. I didn't need to translate it from publication to practice. Just read the review to them. And I said, these are the stories. Does it resonate with you? What do you think about it? What's missing? Where are the gaps? And the experts, the young people, they told me where the gaps were. And that's how we crafted the primary research. And we used different tools. We used dance, we used documentary making, we used photo voice. We used methods that were comfortable, but also we didn't decide from the get-go, oh, I'm going to use photo voice. As we evolved in the study, I asked them, you know, I've got access to these resources. We can paint, we can draw, we can use clay, we can take pictures. What do you want to do? This week, they might feel like, you know, taking photographs. Next week, they might feel like journaling. Next week, we might feel like taking a walk and just having a conversation. So we really, you know, followed a very non-traditional approach of asking them for the questions instead of asking them for the answers, which I found very enlightening. I mean, it helped me grow as a researcher as well. But also using that approach, I was then able to plug the gaps more eloquently and more efficiently into the existing evidence landscape. A second thing that came out of that, we had done the research in such a way that translation didn't have to happen post the study. It was happening alongside the study, and they were active in communicating those findings. So once the study, I think, was maybe 70% of the way done, we then had a community exhibition where we blew up, you know, big photographs of the portraits we took. We had a table that had all the things we had collected in our communities. We had a movie screening, and they could invite anybody they wanted to invite. We invited policymakers, healthcare workers, and for the first time in my life, and I've worked in government, I've worked in university, I've worked in communities, we had over 200 people discussing HIV and art adherence in a documentary movie setting, openly and freely between multiple stakeholders and role players. And it was a really inspiring moment. And I think something that, you know, we can learn a lot of lessons from. So for me, storytelling, storyboarding, using the arts, but also try to think about ways that we can do these systematic reviews and do research. So it doesn't have to follow that linear approach we've kind of put together for ourselves. First we plan, then we do, then we publish, then we disseminate. You know, we can mix those up depending on what are we doing and who we're doing it with, but most importantly, why are we doing it? Thanks.
That's really amazing, Lynn. Thank you so much. And I'm seeing lots of comments about how inspiring, not that you've been inspired, but these stories, but how inspired everyone is about your story. And I think it is fabulous. And I think it's very rooted in the communities. And so using theater and storytelling has gone back centuries, right? Like this is how communities communicate, but our research processes in some ways have, have focused so much more on the written word and on very academic incentive schemes in some ways have reduced the opportunity, I think, for us to continue to think and work with more indigenous forms of communication and engagement with communities to actually impact change and change in health equity, which is what we care about ultimately, or just equity and dignity of human beings in general. So that's really great. And thank you for sharing that with us. While we wait for answers to come through, I'm going to take the opportunity to ask you a challenging question while I have you, Lynn, before I go to the other panelists. Is you mentioned that, of course, naturally, what kind of dissemination strategies and engagement strategies were needed evolved with time. And that makes complete sense. However, in the designing of research and funding for research, you almost have to anticipate in advance what you might need so that you can budget for it, because these things aren't always cheap. Making movies and documentaries, recording theater, photo voice, and doing a roadshow on these require significant resources. How did you grapple with that challenge? Because it comes back to the funding question that we were talking about earlier, is how do you embed that in the way that you design your research and in the way that you submit your proposals to funders, to have that kind of understanding, but also that kind of leeway in changing what these kind of products could look like? Thanks.
Absolutely. And that is very important, Nasreen. So initially, when I applied for this grant in 2017, it was a huge grant because I wanted to test this out, I wanted to experiment with it. But a few years ago, maybe 2 years back now, colleagues and I put out a peer review book around doing participatory research in low resource settings. And there we interrogated how we use participatory methods with little to no resources. If you think about having a conversation and it meant walking with somebody in a park rather than sitting at the desk and talking, that doesn't cost much, right? If you think about the amount that you would spend maybe getting somebody some refreshments or something to eat, you could do that on the go. If you think about things like body mapping, which is, you could draw pictures in the sand, you could use chalk on concrete, you could use resources that don't have to cost anything. If you think about digital mediums, even in low resource settings, people love taking photographs. I use their devices. So if they had a device, or I borrowed them a temporary camera, so one of those disposable cameras, or they had a really cheap phone that they took the photographs with. And we use applications on the phone like TikTok and Instagram to plug these pieces together to make short video clips. And most people have access to that. And if not one person, then, put your participants together in groups and let them work with the resources that they have. But it's just about being creative and using other avenues. However, if you want to go down the route of doing documentaries, then I would suggest make sure that depending on the audience where you want to share that information, that you are using the experts or the people that are able to do that. So if you have access to the resources, use people who are experts in storytelling, documentary making, that can capacitate and train the participants and you to do the work. So, there are options for everybody. You don't have to be put off because you think you're not able to afford or you can't do the study. It is there. And there are many examples in the literature of studies, especially in anthropology, psychology, environmental sciences, that use these approaches, even in visual studies.
Thank you, Lynn. And I think that's a really good message to researchers, is don't shy away from what is impactful just because you can't do it. Bring in the cavalry, right? Build up your army and make sure that you do have others that can do it, but don't not do it because you personally can't do it. So I think that's really great as people think about their knowledge translation plans and how to make research have more impact. Thanks so much. I have a question here for, did any of the other panelists want to respond to that particular question about embedding funding for the creative arts aspect of evidence use and knowledge translation before I move on to the questions? Anyone on our panels? Okay. The next question I have is actually for Lawrence. Lawrence, this is particular about training. So the question is that training in evidence-based practice in medical schools in developing countries is not prioritized in comparison with local health system problems, something you alluded to in what you were talking about, even in terms of research. This in return affects the quality of care provided. How could this be changed in the future, keeping an equity lens in consideration? Lawrence.
Thanks, Nasreen. That's an Excellent question. And I definitely agree. We do need curriculum reforms. We need to update our teachings on research methods in medical schools. Our experience in Cameroon has been that we started off by building capacity among researchers and consultants, and they didn't have time to do the research. So we took it a step back and started training the residents, and they also didn't have the time to do the research. So we took it even further and started teaching medical students. But the medical students can't do their research in a vacuum. They need mentors, they need support, they need resources. And so we expanded this further in order to improve the whole evidence ecosystem in the country as a whole. We started building capacity for journalists, started building capacity for civil service organizations, so that evidence is something you hear about wherever you go, and it becomes more important to everybody. And we started trying to emphasize the value of evidence, and suggesting that it will allow you to use more effective treatments. It will permit you to withhold harmful treatments, and it will also save money, especially in places where resources are scarce. To create curriculum reforms is extremely difficult. Like, there are many medical schools that just don't change what they teach for the longest times. And we had a similar experience. So what we did was we started EBM journal clubs, where we could get small groups of students who are interested in evidence-based medicines, and then they read articles and we discuss the articles, and they start learning the principles of evidence-based medicine and how they can apply evidence to their practice. And then we also started developing evidence-based medicine task forces in hospitals. This was something which some of the hospital directors approved, and it was very good. So every month they would review their SOPs and check whether those SOPs were evidence-based. And it was something which was good, because among the EBDM task forces in the hospitals, some of the medical student trainees will participate, and they were able to, pick up on some of the key bits about why they should question interventions and why they should make sure that what they're doing is based on evidence. But ultimately, all of this only works if you have champions. You need champions who will push for the new initiatives and who will potentially lead them. So I think that might be one of the way forward. So curriculum reforms and champions. Thank you.
Thank you so much, Lawrence. And you speak to, in your response, you also kind of alluded to how important this intersectionality is, because curriculums are technically, something within the remit of the ministries of higher education. And so how does that fit in with what's needed in health, and what evidence is changing in health, and the implications then on how we need to change the way we teach, but also the content of what we're teaching, and the pedagogy behind that, the updating of SOPs, like you said, the updating of clinical guidelines. It's quite complicated, but that's why we think about health in a larger system. But great question from whoever that came from, and thank you so much, Lawrence, for responding. The next question I have is for Ritin. How do we better mobilize resources across evidence networks to address equity issues in the evidence ecosystem?
Thank you for the question, Nasreen. I think there are a few ways that we could mobilize the resources. One of the ways, and I think a very common and effective way of mobilizing resources, is through collaboration and partnerships. And I think that is very strong. If you have a strong partnership and strong collaboration with other bodies who are interested in evidence synthesis, that way there could be some resource sharing. So it's a good idea to foster collaborations and partnerships among different stakeholders. And these stakeholders could be researchers, they could be healthcare providers, policymakers, and also community organizations. So resources can then be pooled, and using a collective effort, we can more effectively address the equity issues. Another way of sharing the resources is cross-pollination of ideas. We can't work in silos. So, promoting the exchange of ideas and best practices among the network members also helps to share the resources and approaches. And whatever you do in your resources, it's a good idea to first have an inventory of what resources you have within your network before you can go ahead and say that this is what you're going to be sharing. So you need to have an inventory or do a mapping of your own financial, human, technological, and research assets that you have. So it's good to know that what's at your disposal so that you can then share it with others. and how much you can share with others. Prioritizing the resources that you have is also based on equity. So we'll have to learn how to prioritize our resources. And I think you said earlier, we need to have budgets and for resource allocations. It's really important to create a budget. So whatever project you're doing, we need to have target the equity issues, define clear objectives, and have budgets in place. What we also have here in Australia in some of our universities is they encourage you to work with collaborations. And the grants are always given when you're working with people from other countries or people from other regions. So, we need to probably harness those, apply for those grants that are out there, and try and make an effort to apply for, the strong big grants that you can have resources. And I think finally, we need to be strong advocates and lobby the government for funding and for, the access to policies and for equity in healthcare and to get funding. So I think that's some of the ways that we could share our resources.
Thanks, Ritin. Interesting points there. And as you talk about incentives for collaborations in Australia, it's really interesting to think about the incentives that researchers have and what kind of incentives the academic infrastructure requires in terms of collaborations, but also in terms of publications. We have a variety of incentives globally about what a collaboration translates into when it comes to publishing, whether sole authorships, first authorships, LMIC authorships, and what that means for those that are part of collaboration. So I think it's all part of our evidence ecosystem is what are the embedded incentives and who do they serve? And how does that then translate into equity as we think about these collaborations? So those are all really good points. Thanks, Ritin. Did anyone else want to respond to that question, or can I ask the next one? Okay, so this next question is for Jordi. How can evidence ecosystems incorporate an intersectional approach to better understand and address the health equity challenges?
Okay, thank you.
you,
Thank you for your easy question. Okay, intersectionality, I think, is one of the big challenges for health equity. So it's definitely something that we need to address about what happened with, to understand all the items. So we all have our own vital trajectory in our own lives, and it's all these things that are building into our own experience of what we are doing. Unfortunately, from the epidemiology tools, it's really hard to get all this complexity into the studies. When we are trying to do research, we're trying to simplify things, to try to find the explanation of how that works. And that doesn't really work well on addressing this intersectionality within people. One solution for that, I would say, we have two. One is co-production. I would say at the point that you are just getting with the people and their full stories. Lynn has making a wonderful explanation about what do you get when you get people with their full baggage into what they want, what they need. This is going to completely transform what you're looking at, and it's going to get into what are the topics that we are addressing. And in this sense, you can see that you are addressing intersectionality in an indirect way by providing voices for the complexity of the individuals that you are treating with. So this point of getting the individuals with other complexities to be able to fit what you are working on, I think that's a good way of addressing from the beginning the issue of intersectionality. The other one is when you're having an equity lens of what you're looking, when you're interrogating your data of saying, would that work in a different population, you're building understanding on how the intervention and why it works. And from this deeper understanding, you can say, okay, then in this case, if someone has more complexity added, would that still be working? And the more that you are building into this understanding of when it does or it doesn't work a particular intervention, you can address whether it will work in a different thing. So providing an equity lens allows you to understand better the issues about intersectionality. You need to keep it in mind. We're not going to have perfect answers, But as you're building better understanding of whether intervention works or not, you're going to get a better sense whether it's plausible to work with particular intersectionalities from different populations.
Absolutely. And as we talk about different populations, we also talk about different sectors, and they all have their own kind of peculiarities as well. And it comes back to, I think what you're alluding to is, you know, it's the human-centered approach. Like we think about people first and not necessarily think about them as patients or as students or, you know, where they fit into the different sectors in which our governments have split us, but actually holistically think about people and the multiple systems that impact them, that affect their access and equitable access to a good life and a dignified life. So that's really helpful to think about it that way, Jordi. Thank you. I see there are some questions in the Q&A for Lynn, but I'm going to go next to Soumyadeep. Soumyadeep, how can evidence ecosystems support efforts to strengthen healthcare systems, particularly in resource-limited settings? So the link between the evidence ecosystem and the link with the healthcare system in resource-limited settings. And I want to specify that the question is about resource-limited settings, not low and middle-income countries, recognizing that there are resource-limited settings in all countries, including in high-income countries. So would love to hear your response to that. Thanks.
Thank you. So I think I'll start with the fact that I don't think any healthcare system anywhere in the world is not limited by resources. Healthcare needs are rapidly increasing throughout the world, and resource limitation is a reality in all settings, in varying degrees, of course, but it's a limitation definitely. And I think in resource limited settings, if we look at it that way, this is where the power of evidence synthesis lies, because when we have a scarcity of resources, we have to be more careful on where we spend the money. And I think the main way to support the healthcare systems, or as in like strengthening healthcare systems, is to first recognize that the evidence ecosystem is part of the healthcare system, not divorced from it, and trying to be really embedded within the system. And the system, I envisage the system as largely, healthcare system has largely two components. One is the physical structure of the systems, and the hospitals and the buildings and the logistics systems, and the resources that are there. But the second part, which is more important, are the people who run the healthcare system. And health systems work on an interface between them. And there is also policies which are made with various actors, with various interests and things like that. The challenge with which we quickly learned from while we were doing health policy and systems research relevant evidence synthesis, particularly with focused resource limited settings, is that these reviews are much more complex. The questions are not just whether it works or not. They are much more broad, and sometimes to answer what was needed to strengthen healthcare systems was qualitative and quantitative both, often a mixed nature of it, very wide and very complex questions. And I think the way evidence ecosystems, like I suggest there are three important things probably which comes top of my mind to answer this very complex question. One is that we need to be really methodologically prepared to be and build the capacity of the evidence ecosystem which we are part of, and embed them within the healthcare system itself, and be prepared methodologically to answer varied type of question, have skills and competencies, build teams accordingly. The second thing is that it's good to start planning about the sustainability of the evidence ecosystem platform or the evidence synthesis platform in itself right from the beginning, without which it really becomes difficult to support healthcare strengthening initiatives. So these are my top two priorities. And the third one, I think, is in every setting, there is uh, various contextually relevant expertise which is needed. As for example, in a countries where there's a lot of human resources for health challenges, that's probably more important to have someone with that subject-specific knowledge in the evidence synthesis platform. Whereas in countries which are seeing economic crises in the nature, it's probably good to have economists and other people also being part of the evidence synthesis platforms which we are looking at. So I think these would be my top three ideas for supporting it. And again, just recognizing that this is a very complex question to answer, and it's by learning by doing process. We learn how to support healthcare systems generating efforts.
Yeah. And it is a complex question. It's a complicated system. We're asking about two different systems and how do you link them up? And I think Lynn also shared with us her frustration about there are systematic reviews, there are answers, we have the evidence, but sometimes things just don't happen. So where is that implementation aspect, particularly as it translates then into healthcare settings? So thank you for at least taking a shot at that particular question. Did anyone else want to respond to that question before I move on to my very last question for all the panelists? Okay, so since Soumyadeep, I already have you on my screen, I'm going to start with you. So I guess the question to all panelists is, what gives you hope?
I think I'm an incredibly hopeful person, and the fact that we are having the World EPHC Day, something being celebrated every year, and with so many people coming in, gives me a lot of hope for what work we can do. I mean, I started working in evidence synthesis in India around 7 or 8 years back, and at that point, I didn't think we could be in a place where there would be a World Evidence-Based Healthcare Day. So the fact that we are here today gives me a lot of hope in terms of the work we can do in the future.
Okay, thank you so much. So I'll go around my screen asking the same question to each of our panelists as you think about the evidence ecosystem, your experiences, that of others, and the stories you've heard on the panel today. Ritin, what gives you hope?
Okay, so what gives me hope? You know, seeing all of you here today, your commitment, early morning, late night, you know, attending the conference, and your commitment to the equity, this is what gives me hope. I've been in the system of evidence-based care for the last 26, 27 years. And I think that the collaboration, the networks that we have provided, and the respect that we have for the local priorities, that's what gives me hope. And to see how far we have moved from the time evidence-based practice got instituted, 1996, 97, as far as I remember, to now, and the changes that has happened, that's what gives me hope for the future. But what I also think is that we need to not solely rely on others. We need, as individuals, we also need to take responsibility and start thinking about equity in our own lives, in our own work areas. So these are some of the things that are really important, and that will help. So as individuals, we need to be taking part in equity-focused initiatives.
Super. Thank you, Ritin. You've put us all to task. Jordi, what gives you hope?
Thank you. Well, what gives me hope is that when I started working on the health equity area about 15 years ago, like a lot of times you were talking about equity, people look at you like you had to hedge, like what is this person talking about? And right now, like you go to any conference and health equity is going to be for sure something that we are talking about. And when you look at the new generations, they're absolutely passionate about health equity and to make a difference on the inequities in health that they see in their daily lives. And I think that the impetus of the new generations give me hope that we are in really good hands on the future to address these things. I will say the challenges are huge, so we are definitely not in a position that we can relax or that we can be idle. But I think there is a lot of people with a lot of energy coming ahead, and that give me a lot of hope and energy to keep working on this area in order to address these important issues.
Thank you, Jordi. And I encourage panelists to look at the chat because there's also lots of comments that are coming through there for all of you. Lynn, what gives you hope?
For me, it's just seeing, you know, I started working in QES, I think about 7 or 8 years ago, and seeing where it is now.
I'm not sure.
So qualitative evidence syntheses, so systematic reviews of qualitative research. And I know some people have probably been doing that for much longer, but I know when I started here in South Africa at the Center for Evidence-Based Healthcare, there was nobody doing this work. And so I basically started with a few colleagues, you know, figuring out how to do this, how does it all work, and where we are now in terms of the methodologies, and being at the colloquium a few months ago and seeing how excited people are about introducing new methods, you know, experimenting with non-traditional approaches. I feel like that's how we get different answers. You can't keep doing the same thing and expect a different outcome. So that keeps me hopeful and excited about the future. You never know, we might start dancing as synthesis, who knows?
Maybe we'll have more exciting conferences too. Where we can showcase different kinds of outcomes and outputs. And I know many of them are already quite innovative that way. Thank you. Thanks, Lynn. And Lawrence, last but not least, what gives you hope?
Thanks, Nasreen. Again, as everybody mentioned, just the fact that we are here, we are talking about equity, we are measuring equity, we are looking for different ways to move the dial. That gives me hope because things are way much better than they were 10 years ago when, you know, we were young in our career. So I do think things are getting better, and I am extremely happy to see equity on the forefront of all the conversations we're having in all facets of the evidence ecosystem.
Thank you so much, Lawrence. So that brings us to the end of our discussion section. Thank you all for your questions. Many of them were answered in the Q&A directly by panelists, so I didn't bring them up on the panel here, but hopefully your questions have been answered. You've got another 2 minutes to ask any other questions to them that you want. But I'm going to hand back to Bianca, our host for today at JBI. And thank you all for attending today. It's been a pleasure being your moderator and chair. Thank you.
Thank you, Nasreen. And seriously, from the bottom of my heart, a big thank you to you and to all of our panelists. It's such an engaging discussion. It's amazing how fast 75 minutes can go, and I would have happily stayed here for another few hours, but alas, it is early and late for many, and we're so grateful to everyone for engaging in the chat and asking questions and submitting your questions during registration as well, which were the questions that Nasreen were asking. But tonight or this morning, depending on where you are in the world, is just the beginning of World Evidence-Based Healthcare Day. And so just a reminder that over the next 48 hours, there's more events. If you check out the website, discussions, activities, we really encourage you to continue these conversations over your preferred social and digital media platforms. If you go to the website, we've had some wonderful stories tonight from our panelists, but you can read 55 blogs. So there's been some amazing stories and experiences that have been shared from around the world from our global evidence community on their challenges, on the ways that they've addressed and experienced inequity or equity and how they've grappled with that. We also have 20 vlogs in different languages. You can download resources in 10 different languages if you'd like to get involved. And so once again, a huge thank you to all of our panelists and our attendees. I hope that you agree that it's been a fantastic session. This recording will be available via YouTube early next week. And it has been my absolute pleasure to convene this webinar and to officially kickstart World Evidence-Based Healthcare Day for 2023. We look forward to seeing you and interacting with you over the next few days, and thank you for joining.